No more counting sheep for insomnia? Treating chronic insomnia with cognitive behavior therapy for insomnia could be more cost-effective than current pharmacological treatment. Sleeping tablets can become very expensive if the medication changes from generic to brand name or as dose and frequency of use increases. Unfortunately, hypnotics or sleeping tablets are not usually effective for chronic insomnia. They can also cause unpleasant side effects such as daytime drowsiness or a feeling of having a hangover. CBTi therapy includes a range of strategies to help insomniacs associate nighttime with sleep time. Stimulus control therapy aims to associate the bedroom with restful sleep. Using soft colors in the bedroom and removing clutter, a calming space is created. Ideally, the bedroom should only contain bedroom furniture, so no TV or computer to distract the sleeper. Sleep restriction therapy limits time spent in bed to actual sleeping time. This means getting out of bed when awake, whatever the time. Whilst this creates mild sleep deprivation, it also ensures a connection in the mind between the bedroom and sleep. Paradoxical intention can be used to manage the situations where it is difficult to get to sleep rather than to stay asleep. It involves forcing an awake state without trying to go to sleep. Finally, biofeedback uses sensors on the body to measure the body's physical responses. The biofeedback machine indicates changes in muscle tension and heart rate. This helps the subject to control breathing and body responses more effectively. A U.S. randomized, controlled trial of the effects of CBTi tested the effectiveness of the therapy for insomnia and daytime functioning. 34 randomly selected college students completed either 6 sessions of CBTi or a 6-week waitlist control. All participants completed a week-long sleep diary and underwent actigraphy. Actigraphy is a non-invasive method of monitoring human rest and activity cycles using a sensor which is worn by the patient at all times. The subjects also completed questionnaires about sleep and daytime functioning both before and after treatment. The treatment group repeated all measures during a 3-month follow-up. The subjects who underwent CBTi showed greater improvements in sleep efficiency, sleep onset and the number of awakenings. They spent less time awake after sleep onset and had better sleep quality. They also reported a reduction in insomnia severity and general fatigue than the WLC group. These improvements were still in evidence at the 3-month follow-up. It was also noted that the results were even better after following the recommendations to go to bed only when sleepy. They were also advised to keep regular hours and to get out of bed if getting to sleep was proving impossible. A New Zealand review of the cost-effectiveness of CBTi backed up these results. 21 insomnia treatment providers were recruited using snowballing sampling. Snowball sampling is also called referral sampling, as future subjects in a study are recruited from acquaintances of existing subjects. Information gathered from the interviews was used to estimate treatment uptake and costs as the basis for a decision analytic model. The results highlighted the fact that insomnia treatment in New Zealand is quite unstructured. Despite this, the net annual benefit for treating insomniacs was judged to be reasonable compared with the cost of using drug therapy. Cognitive behavior therapy for insomnia is not in widespread use, however it does provide an alternative for treating chronic insomnia. The uptake of CBTi is sometimes influenced by the scarcity of clinicians who are trained in providing CBT specifically for insomnia. Another issue for its use in primary care is the length of treatment. Generally speaking, 6 sessions is usually considered to be too long for inpatient care. Perhaps for these reasons, insomnia remains an undertreated disorder and a considerable burden to those who suffer from it.